The construction and use of growth charts are not without controversies. There are people who insist on using the growth references, which describe how children grow at a particular time and space. Others would embrace the notion of growth standards, which describe how children should grow when their health needs are met. It's sometimes difficult for these two camps to talk to each other. And indeed, it's just like 雞同鴨講 or 講人自講. So in the next 15 minutes or so, I'm going to give a self-talk on the WHO Multi-Center Growth Reference Study, MGRS, and the resulting WHO Child Growth Standards. I'm just going to state three salient features about this study and standards. Now, these are intended to be universal standards because there is solid evidence that children of diverse ethnicity grow very similarly for the first 5 years of life in optimal environment. So the study drew samples from privileged and healthy communities in 6 sites globally. The second feature is that the study adopted a prescriptive approach. The participants had to meet selection criteria of specific growth or specific health-promoting behaviors. I won't go into these, it has been mentioned by Connie. So the aim is to establish breastfeeding as the norm, as it is well known that breastfed babies and formula-fed babies have very different weight gain patterns. Number 3, the meticulous conduct of the study with stringent implementation of protocol, rigorous quality control and management of data, as well as using contemporary statistical methods ensure that the growth curves so constructed are of the highest quality. This is the same map as Connie have shown. The data collected over 8,000 children aged 0 to 5, including a longitudinal sample and a cross-sectional sample. With the data available, the multi-center growth reference study group went on to assess the differences in linear growth among the populations to see whether it is appropriate to pull the data together to construct a single reference. You can see here that the mean length from birth to 2 years for the 6 sites are strikingly similar. Same for the mean height from 2 to 5 years, although there are some more variations towards the upper end of the age range. And then statistical analyses were conducted. First of all, the variance component analysis of length in longitudinal sample show that that variability of individuals within sites accounted for 70% of the variance, whereas the variability among sites only accounted for 3% of the variance. That means the spread of the individual data with respect to the mean is much wider than the site variance. And then there is the assessment of standardized site effects, SSE, which was defined as the site mean minus the pooled mean divided by the standard deviation of pool mean. Essentially, it means the standard deviation score or the SAT score of the site mean with respect to the pool mean. This is worked out for each site and at each of these ages of length and height. It was predetermined that pooling would be appropriate if the differences were less than plus minus 0.5 of a standard deviation, which correspond to the medium Cohen's d effect size. So the result shows that the SSE values for length varied between minus 0.33 to plus 0.49 standard deviation, whereas the heights vary between minus 0.41 to plus 0.46 standard deviations. Oman accounted for most negative values, whereas Norway and Brazil most positive values. And excluding individual sites from the pool sample had minimal impact on the pool statistics. Even excluding Brazil or Oman shows very, very little difference. So the conclusion was that it is appropriate to pool the data of the 6 samples to construct a single international growth standard. So the WHO Child Growth Standard was published in 2006. Here in Hong Kong, the debate began with the publication of this article online in June 2007. They found that children born in 1997 are shorter at 3 years. The height Z-score for boys was minus 0.34 and for girls minus 0.38 with respect to the WHO growth standard. So the conclusion was that this standard was not suitable for Hong Kong Chinese children. In November 2007, the Hong Kong College of Pediatricians organized the pediatric update to discuss this issue, and an alternative view was presented based on the same data. As you can see, the same data, but the conclusion, the interpretation was that the mean Z-score of heights of Hong Kong 3-year-olds and other 4-year-olds as well from other data actually fall within the range of plus minus 0.5, which was considered as normal site variation by the MRGS. In the following year, this article was published on paper in the Archive of Diseases in Children, and there was a commentary in the same issue that raised the same alternative view. I quote, "When the data are added to the plot, they fall into the same range. The growth pattern is actually not unlike those from the MGRS sites. The magnitude of the deviations falls into the range that the WHO consider to be normal site variation." So this is the plot. Okay, these lines are the means for the 6 sites, and this red line in the middle is the pooled mean, and these 2 dots are the Hong Kong 3-year-old data. Okay, some 15 years on, with the availability of the Hong Kong growth study data and other more recent data, it is possible to reevaluate the appropriateness of the WHO child growth standards. In order to test for the goodness of fit, these are the criteria. For the mean, excellent fit is taken as a difference within plus minus 0.17 of a standard deviation, that is a quarter of a centile space. Good fit is half a centile space, and acceptable fit as defined by WHO. And for the tails, the proportion of children below minus 2 SD or above plus 2 SD should not be substantially in excess of or less than the expected 2.3%. As far as the length height is concerned, you can see that the Z-score of the mean for boys are all falling within the good to excellent fit. And for girls, also, except for the age 2.5 to 4 years of age, they fall into acceptable fit. This is weight for age. They're largely excellent and good fit. This is BMI. Again, excellent to good fit. And head circumference. Okay. For the birth weight, this is the public hospital data, and this is the private hospital data. They all fulfill the criteria of satisfactory fit. As Hong Kong children are shorter, people are naturally concerned that the child health, the WHO child health standard might identify an excessive number of children with short stature. Now here, for boys, -2 SD will screen out between 2.4% to 4.7% of children. And for girls, at 2.7 to 4.5%. Now, the following few slides show an overlay of the WHO child growth standard in blue dotted lines, and the Hong Kong growth reference, orange solid lines. The three lines are 0.4th percentile, 50th centile, and 99.6th percentile. Now you can see that this is weight for age, okay? The top one is girls, the bottom one's for boys. You can actually see that the orange lines are sitting well within the blue lines, okay? This is length height for age charts for girls and for boys. This is BMI for age charts for girls and for boys. Now, interestingly, you see at this age, particular age, the WHO chart is actually able to identify a small proportion of Hong Kong Chinese boys who are probably overweight or obese. This is head circumference. So you can see that all the orange lines are actually within the blue lines, or they can be interpreted that these Hong Kong data could be seen as a subsample of the WHO data. Okay, at last, the Hong Kong growth study was able to produce and recommend the three charts as highlighted by Connie. So I think the growth references camp would be delighted to see the Hong Kong growth references. There is sound evidence to show that the WHO child growth standard is suitable for Hong Kong children. And to reap the benefit of both, you can use the hybrid chart, which consists of the WHO child growth standard 0 to 2, transitioning to the Hong Kong growth reference 2 to 18. Now, here are some examples of countries which have adopted the WHO child growth standard in part or entirely, and they are using this currently, like the US CDC, 0 to 2, the UK, 2 weeks to 4 years, Australia, 0 to 2, Canada, 0 to 5, Taiwan, 0 to 5, and Korea, 0 to 3. Okay. China is interesting, but I don't think we have time to go through this. So thank you very much.
The WHO growth standard versus the early the Hong Kong 2020 growth curve for the young children is pretty comparable. It really depends on which clans do we belong to. But then, say if the parents would really like to know which do we need to which one do you prefer to adopt, the hybrid one or the Hong Kong 2021? So what would be
For me?
For the parents?
For the parents?
Yeah.
Well, I don't know. I think the parents will go to a healthcare provider, usually either MCC or the private clinic or whatever. I think it's maybe up to the clinician to choose whichever, growth charts they like. It doesn't really matter, But at the back of the mind, how what the chart means. Okay, whether it's a standard, whether it's a reference, and how this constructed, what are the limitations, and so on. Okay, I think to the clinicians, any growth chart with reasonable validity will be fine. The growth chart are only one item in the clinician's toolbox for the health assessment. Okay, so it's up to the clinicians to use this tool intelligently, right?
So 你啱啱就回應咗阿林醫生兒童醫院嘅林醫生嘅問題嘅 comments 啦，咁就係話咧父母其實而家好多時候都會自己上網啊睇唔同嘅 growth standard growth curves 啊咁樣，咁佢哋可能就會有好多呢啲咁嘅 confusion， 咁所以咧 as clinician 就好似頭先 Dr Matt 同埋 Dr Leung 咁樣講啦，即係其實 growth curve 只不過係對於 clinician 嚟講係一個 toolbox 係一個 reference 嚟嘅啫，最緊要其實都要睇翻佢即係 holistic 嘅 factors 點樣影響到小朋友嗰個生長，咁希望嗰度可以減低翻parents 嘅 confusion 同埋佢哋嗰個 stress 喺呢一方面。
其實我想正就係呢樣嘢咧，就係令到佢哋 more aware， 即係自己嘅小朋友係咪過肥啊，或者增長有冇問題？如果近時佢根本都掌握唔到，佢都無從去問啦嚇。如果佢見到即係我都俾人問好多即係 cross the percentile 等於乜嘢啊咁樣，咁咪趁呢個時候即係我哋可以去解釋俾佢聽咯。即係我諗就唔係即係我相信即係個用意唔係話我哋收埋啲嘢唔俾個父母，而家都唔能夠啦，係咪？即係佢自己都會度，市面上都好多 app 去度。咁咧就與其係即係我哋唔 provide 我哋嘅 updated reference 俾佢，不如就我哋俾個機會佢哋問我哋。咁所以我諗個 e-health 咧，我係即係舉腳贊成，一定係一個最好嘅地方。咁但係頭先你講得啱，就係話即係唔同嘅 source， 即係好多人唔同嘅度。頭先阿 Patrick 講下，好多人度未必係健康院度㗎，可能 HA 度，可能係其他地方度。但係我哋真係有好多 filter 所以做嘅，即係喺IT wise。Likewise 咧，即係我哋都拗咗落用 WHO 好啊，定用香港 standard 好咧？其實又可以諗一諗喎。其實我只要有啲 data， 我撳個掣，我咪轉咗 WHO 咯。我撳個掣就變咗香港咯。頭先 Patrick 都講，頭先阿 Pauline 都講喺健康院嘅醫生嘅台面，其實都有兩套 standard 啦，係咪啊？你可以轉嘅啫嘛。咁其實喺個 app 度我哋已經轉到，而家好容易嘅啫嘛。咁我哋有冇諗過呢啲咧？嗱，另外一樣我想問一問 Shirley 嗱，即係我哋有 WHO 啦，我哋有香港啦。頭先你話冇時間講，大陸點咧？嗱，而家成個香港大灣區啊嘛，咁即係呢啲細路仔嗱，我哋都有成10幾萬嘅即係高才通啲人已經嚟咗啦。咁佢哋有細路仔啊，1個至2個，咁成幾10萬個細路仔喎，可能將來。咁用咩 standard 咧？係咪即係翻到我今日喺香港就用呢個，跟住上咗Tony 嗰度，依樣用深圳嘅 reference， 咁點搞咧咁樣？
中國自己係有 reference 嘅，係咯。自從2023年，即係舊年嘅3月開始咧，就 recommend 用佢哋喺2015年嗰個 national survey 所 construct 出嚟嘅嗰個 growth reference 嘅。咁之前咧就佢哋嘅 MOH 咧Ministry of Health 咧都係 recommend WHO 嘅。咁點解話要轉咧？就係話即係舊年話轉咧，就係話咧中國嘅小朋友咧就已經超英趕美啦。咁咧就所以咧就我哋要用即係新嘅 reference 啦。咁所謂超英趕美咧，如果你睇翻佢哋嗰個 set score 咧 on WHO 嗰度咧，係其實係都係 within 0.5嘅。我唔記得個 number 啦，係加0.4幾嘅。 weight 同埋 height 都係，即係 overall。所以佢哋就話啊，因為我哋已經超英趕美啦，即係已經過晒WHO 啦，所以我哋用新嘅 reference。咁但係其實咧，呢個都可以商榷嘅。我用翻舊嘅都得嘅，係咪？都冇問題嘅。咁 in fact 咧，2025年佢話咧已經超英趕美。其實咧你睇翻咧2005，因為佢哋10年做一次嘅，1975年、85、95、05。15咁樣啦，你睇翻2005嘅數據咧，其實同15爭少少啫，即係嗰個 secular trend 係高咗丁士咁多嘅啫，係啦，反而咧你再睇翻95嗰個咧就比較差多啲，但係95其實咧就已經過咗少少，已經係加咗啲咁多，我唔記得嗰個 number 係幾多啦，即係已經喺嗰條線嘅上邊嘅啦，已經喺個 mean 嘅上邊少少，就75、85就當然係 negative 啦，即係如果你睇翻。係咁就係咁啦。
唔係，所以我更加覺得我頭先講嘅嘢係即係唔係即係好離地嘅。即係如果我哋有 data 係咪啊？我哋一係用電腦，其實我撳個掣就可以轉個 standard 啦嘛，係咪啊？你中意用邊個都得㗎？可以。係啊，即係或者你要將來去其他地方移民或者點樣都好，咁我哋啲 data 我 plot 落去已經搞掂啦嘛。咁點解我哋唔做咧？咁但係我諗唯一可以做咧，即係我覺得係應該係 e-health 做嘅，e-health 嘅同事做，我非常之希望佢可以 accomplish 到呢個目標。
即係如果你有好多，即係而家你當大陸有好多人嚟香港，咁你整個大陸嘅 chart 喺度咯，sorry。係咯。整個大陸 chart，咁你咪中意你 plot 邊度都得啦。